Hi everyone, welcome. I am Angela Love-Zaranka, Program Director at Lactation Education Resources, here to welcome you to exam prep for the IBLCE exam. 30 days out and you've got this. How about you, Sekeita?
Yes, definitely. Hello, I'm Sekeita Lewis-Johnson. I am the Accredited Provider Program Director here at LER. Just sending warm greetings to all of you who are coming in to get prepared and ready to go.
Excellent. So just a little bit of background about Sekeita and myself. I'll introduce me, she can introduce her. So I've been working in community support for over 30 years and am a board certified lactation consultant. I've worked in private practice and hospital. And one little pro tip, I actually was also on the IBLCE board of directors and on the exam review committee. How about you, Sekeita?
Yeah, so I am a nurse. Most of my work has been in the hospital setting up until 2000. Oh no, that's a lie. 2020. Why did I say 2000? That was okay. 2020. So y'all know what's happening in 2020, right? I also have a background as a nursing instructor. I am still practicing as a IBCLC in my community and private practice, as well as a birth doula. So doing all sorts of things, wearing all sorts of hats. And so yeah, just here to bring some knowledge and hopefully help you prepare.
Okay, this is great. So let's get started. Now, if you would like to ask questions for us, please feel free to do so. If you are participating today via a computer, you will take a look at the GoToWebinar interface and you can see where that blue arrow is pointing. That little spot is where you can type in questions. You can also comment if you'd like. And so why don't you give it a try, find that little spot, that bar, and type in where you're participating from today. If you are participating on a mobile device, take a look at the green arrow. It's pointing to the question mark, and that's where you can either ask questions or you can comment. And we've got a couple of other folks on the call today to help Sekeita and I out. One is Julie Grimes, who is a board certified lactation consultant as well, works in our amazing customer support and our content teams. And so she is ready to answer your questions. She'll save a few for us at the end so that we can answer for everyone, or during these, we'll stop at a couple of points and she'll flag those questions where we need to respond so that everybody can hear the response. And then we've also got Jill. Jill is part of our amazing tech team. And so Jill is here if you're having any tech issues. Please type them into the questions, type them into the chat. Okay, so just a few ground rules here. Please don't photograph or record the information with a camera, a phone, or any other equipment. We are recording it, and you're going to be able to review this session as many times as necessary. Also be mindful that Sekeita and I have added these pictures, and we have permission from the families to provide them for this broadcast. However, beyond that, we do not have their permission to share this information. Now, we are going to ask you a few questions after Sekeita starts. She's going to do a presentation. I'll do a presentation, then we're going to practice with a couple of questions, give you an opportunity to respond. Also, regarding the GoToWebinar interface, you saw that spot where you can ask questions. We'll also take a look at that spot and see if you can find that another bar which says handouts. And so we have included some of those key slides, which we think are going to be best in order to help you to study for the exam. Okay, here we go. So we're going to start with medications. Sekeita, it's all you.
Thank you, Angela. Excuse me, I have a little frog in my throat. So we're going to start with medications. One of the things that I want you to be aware of is that in the handout, all of the medications, all of these slides regarding medications is in your handout. So it might be helpful to just kind of listen to this and follow along through the actual slides, and then you'll have all the information that you need in that handout. All right. So I'm going to go over some key points right now about medications. And one of the first things is to remember that, the amount of medications that gets into human milk or breast milk and the safety of that is based on many, many different factors. And so when we think about those factors, there's several of them. And so again, don't try to memorize all of this. Just try to lean into some of the principles because the exam itself is more practice oriented. So for starters, a medication can only enter into milk if it's circulating in the mother's or the lactating person's plasma. That's the blood. So only if it's circulating can it get into milk. All right. When we're thinking about other key points, we often look at the milk to plasma ratio. And that's a ratio that's useful to evaluate the concentration of the medication in the plasma compared to the milk. It is the ratio of concentration of the drug in the milk divided by the concentrated in the lactating person's plasma. And that's where they get the ratio for. This is a useful indicator of that can help us determine, excuse me. I have a frog. I got a cough. I am so sorry, you all. I'm battling this little cough, so please bear with me. This is the indicator that medications that may enter at milks could be at higher levels. So when we're thinking about ratios, we're thinking about a high ratio versus a low ratio. In Hale's book, Hale's determines anything that's less than 1 as a low ratio. So a low ratio indicates that only minimal levels of the medication is transferred into the milk, which is preferred. All right. Ratios that are greater than 1 can enter into the milk easily. All right. So the relative infant dose is another important clinical parameter to determine safety. It's usually expressed as a percentage. All right. So it's the percentage of the maternal or lactating person's dose. So according to Hale, and when I talk about Hale, I'm talking about Hale's big publication of medication in mother's milk. So I'm just going to shorten it for Hale going forward. So according to Hale, medications with a relative infant dose less than 10% are considered relatively safe for full-term infants. And notice that I said full-term infants, okay? So a relative infant dose greater than 10% for a full-term infant should be cause for caution and further assessment of that situation, all right? Also remember that during the colostrum phase, medications transfer into milk easier due to the large gaps in the alveolar cells. However, the total dose that is transferred to the infant is low, and it's low because there's limited milk volumes that the infant is able to get during the colostrum phase. All right, other key points to consider. We're going to talk about half-life. And as you can see on the slide, half-life is usually represented as a T and then the the script of half, right? So the half-life of a medication is the measure of how long it takes for the drug to decrease by half. It's expressed in hours, and medications with shorter half-lives are ideal, all right? So make sure that if you're looking at any drug, it's the amount that it takes for the half-life. So a short half-life is considered about 1 to 3 hours. And if you think about that, that's almost how often babies feed, 1 to 3 hours, right? So in saying that, is expressed in hours. Another key point to remember is that most medications enter milk at clinically insignificant levels. So again, most medications will enter milk, except most of them are at levels that will not impact the infant. But once a medication does enter the milk, oral bioavailability of the medication becomes important. And so oral bioavailability refers to the ability of a drug to reach circulation after it's ingested. So drugs with low oral bioavailability are generally poorly absorbed in the infant's GI tract, and they are destroyed either in the gut or they're taken up by the liver prior to entering into the infant's circulatory system. So basically, you know, it's just like the drug does get in the milk, it does enter into the infant's gut, but then it's taken up, it's destroyed, or it's taken up by the liver, so it never gets to the infant. So from a practical standpoint, you want to always make sure that you're looking at medications from their lactation safety profile. And some of these key points are related to that safety profile. The lactation risk category is a great start always, but you always have to take a deeper dive based on a different set of circumstances. And you have to also be cautious or more cautious with premature infants or very new infants, newborns. Other safety considerations include being cautious of high vitamin doses and avoiding high doses of sedatives, opioids, radioactive agents, and chemotherapy, and high doses of iodine. So this is just a real quick summary, is that remember that many drugs transfer into the milk if they are high in concentration in the maternal plasma. Medications, and I didn't go over this, but this is something I really wanted to kind of separate because there's always some questions about this when we do this 30-day review. So medications with small molecular weights can also pass into milk easily by traveling through very small pores. HALE defines small molecular weights as molecular weights less than 500 Daltons. Now, in this latest publication, that is on page 7, but I also went on further and I read on page 15 that it's also listed as less than 200 Daltons. And so I wanted to kind of give you just that idea of, again, sometimes there are some changes within textbooks, but for the most part, on the very first page, there's a table in this new publication, and it's listed as less than 500 Daltons. All right. So you basically, the other thing is protein binding. That's another factor regarding, you know, how easy milk gets into, how easy medications get into the milk. Protein binding. All right, so most medications that circulate in the blood are bound to proteins. The biggest protein being plasma albumin. And there are other proteins, but most drugs are circulated through the proteins. If a medication has a high affinity to bind to proteins, it cannot enter the milk easily because it's bound in that site going through that blood. So the higher the percentage of binding, the less likely the drug is to enter into human milk. So the safer choice would be to choose medications that have high protein binding in order to reduce the infant's exposure to the medication. Another point to remember is that medications that can pass into the brain easily can also pass into milk easily. So in summary, ideal medications are those with short half-lives, high protein binding, low oral bioavailability, and high molecular weights. All right, I'm going to review medication by classes now. And as you can see, I've listed the lactation risk categories based on HALE. However, don't freak out right now. I want you to know that the L rating is not something you have to memorize. What you do need to have is a general idea of the applications or the categories of medications, meaning like, why is this medication being used if it's given to you in a question? But it's highly unlikely that lactation risk categories will be on the test. So let's start with antibiotics. Antibiotics are commonly prescribed, and many providers and clients will always have questions about their safety regarding breast or chest feeding. And just when I say many providers, I really mean that, because a lot of times there's an assumption that, like I said, most medications enter into the milk at insignificant values. There's always the assumption that this medication could potentially cause harm. So I just want you to know that there is, you'll always get questions. So as a general rule, antibiotics are compatible with providing human milk. There are a couple medications listed on this particular table, ciprofloxacin and erythromycin. They're listed as L3s. And they're listed this way because they've been associated with GI concerns. However, one of the other biggest challenges, or one of the things of concerns when you're taking antibiotics, or to consider when someone is taking antibiotics, is that it changes all of our GI flora. It changes our flora, and there's the potential to develop antibiotic resistance. So the other reason why I really love this particular slide and this particular class of medications, because if you're not familiar with the many names of drugs, it might help you to know that a lot of antibiotics end in CIN as an ampicillin. That's true for many, but not all antibiotics, but it is a helpful clue for you. Antifungals are used to treat fungal infections, such as the vaginal yeast infections, oral infections such as thrush or Candida albicans, and topical fungal infections. I think I just said fungal. I meant fungal, okay? Topical antifungals such as nystatin or miconazole are used to treat yeast and are considered safe as long as minimal amounts are applied to limit the oral absorption by the infant. All right, moving on to pain medicine. Analgesics are pain medications that are common after birth. Some medications are combination medications, and so whenever you see a combo medication, it's best to look them up. So for example, Tylenol 3s and Tylenol 4s. Tylenol by itself is acetaminophen, and by itself it's an L1, which is compatible with providing human milk. However, if you combine it with codeine, it changes the dynamics because codeine is classified as an L3. For a minute, codeine was classified as an L4, but in this latest publication, it's classified as an L3. According to HEL, L3 is classified as a medication that is presumed compatible. So in practice, you really want to take a deeper dive into whether this choice is appropriate for your client. Ibuprofen, Motrin, is another common pain medication used for pain. If you look at this chart, you'll also see that aspirin now has 2 different categories. And this stuff is new to me too, because it's like reading the new publications, like this is new hot off the press stuff, right? But aspirin now has 2 categories. If the dosage is greater than 81 milligrams, is considered an L3, which is presumed compatible. And low doses are considered an L2, which means probably compatible. So HEL warns us to avoid aspirin at higher doses during lactation when infants have a viral infection. Furthermore, he states that while direct use of aspirin in infants and children have been associated with Reye syndrome, the use of 81 milligrams a day or even just a single dose of 325 milligrams a day in breastfeeding mothers have not been linked to an increased risk of this syndrome in infants. Morphine is a potent medication, and that's also typically used sometimes in the birthing area and after birth. And it's classified as an L3. It's used in the spinal cavity for C-sections and sometimes postpartum surgical pain. And it appears to be safe for limited use. So morphine is considered the best choice for limited use because it is poorly absorbed in infants. And Dilaudid is another potent pain medication that is presumed compatible. Please note that when we talk about compatibility, the compatibility of medications are basically only exist when they are being used as prescribed. Other key things to note about some pain medicines is that with infant, there are some concerns regarding sleepiness, poor feeding, sedation, and yes, respiratory issues. Anticonvulsant medications is also anti-seizure medications. As you can see, they have varying lactation risk categories. A common one that is used in the birthing space is magnesium sulfate. It's really a laxative, but it's used to treat preeclampsia and sometimes preterm contractions. There are still hospitals that are telling people that magnesium sulfate is incompatible with breastfeeding. Literally, I just had a client about 2 weeks ago who shared this with me. They shared their story. So anyways, the infant concerns in this category are sleepiness, poor feeding, and irritability. When you look at the other hand, when you look at valproic acid, this is potentially hazardous and should be avoided. And I do want to say that last sentence that I just read is actually from chapter 5 of the core curriculum. And it actually noted that in there. So I just wanted to give you a little gem there. Slide 13, antidepressants. These 3 antidepressants appear to be compatible with providing human milk. We know that postpartum mood disorders are common, and there are some conditions that will require medication management. So these medications are in a drug class called selective serotonin reuptake inhibitors, and they are the most prescribed. These medications are listed as an L2, as probably compatible according to HELS, and Zoloft seem to be the preferred. However, infants should be monitored for sleepiness, poor feeding, low muscle tone, and agitation. And infants may exhibit neonatal withdrawal symptoms if exposed to certain SSRIs while in utero. And I said SSRI, that stands for the selective serotonin reuptake inhibitor. That's the class of drugs, and we kind of use that acronym to describe that. Antihypertensives are used to help decrease high blood pressure. As you can see, they also fall in varying lactation risk categories. Just know that infants should be monitored for sleepiness, pallor, poor feeding. And also note that hydrochlorothiazide and furosemide are medications that have the potential to reduce milk supply by depleting maternal blood volume. That's also noted in HELS, so I wanted to point that out, which means that you also want to be monitoring for maternal or a lactating person's milk supply. Vaccines. Generally speaking, vaccines are safe while breastfeeding. According to Lawrence and Lawrence, Breastfeeding, a guide for the medical profession, 9th edition, page 391. Because sometimes people have to read it for themselves because they've been told different things. Smallpox vaccination is inadvisable for the mother of any younger infant, younger than 1 year of age, whether they're nursing or not. It's the personal contact, not the breastfeeding, that causes the risk. Therefore, there's no advantage that exists to weaning if vaccination is necessary. The vaccination is not given routinely and is rarely indicated. However, yellow fever vaccine is a different story. The yellow fever vaccine is a live virus vaccine. There are case reports of encephalitis in breastfed infants, which is a brain inflammation, in breastfed infants whose mother received the vaccine. Infants greater than or equal to 9 months of age can be vaccinated themselves for travel to endemic areas, but there is an increased risk of encephalitis from the vaccine in infants 6 months of age or younger. So the recommendations are to avoid vaccinating breastfeeding or chest feeding mothers with infants less than 9 months of age. If medications and pharmacology is not your strong suit, I highly recommend that you read chapter 5, and it's called Lactation Pharmacology in the Core Curriculum for Interdisciplinary Lactation Care, 2nd edition. It was extremely helpful to this presentation, but also there are some nuggets in there and some things that will help you focus your studies. So there's that. I want to pause right now before I go to Angela, before we go to the next section, and ask Angela if there's any questions that I need to answer before moving forward. No? Yay, good,
No.
take it away.
I know, you explained everything just so perfectly, there's no questions. Okay, good. I was a little anxious, so now we're going to go into the next section, which is breastfeeding beyond the first month. And if you'd like more information about this topic, please refer to the corresponding courses from our lactation consultant training programs, such as infant growth and development, breastfeeding the older nursling, and weaning. So if you need more information about these topics, please do take a look at some of the offerings that we have. Also, we've got a really good overview in our exam review content. So let's not hesitate, let's keep going. So now when counseling clients with older nurslings, be mindful that the number of feedings and the time at breast may fluctuate greatly. Babies might return to more intense breastfeeding to adjust their parents' milk production as needed, which is something referred to as growth spurts. Now, although every baby is unique and every baby is different, They usually do clump around certain times or certain ages. Usually it's at around 2 to 3 weeks. There's another one that happens at around 6 weeks, and then again at 3 to 4 months. Remember that developmental milestones may increase night waking and nursing. These little ones seem to be just too busy exploring the world during the day in order to spend time at the breast. They may miss something if they do. Therefore, they're going to wake up a little bit more in the middle of the night in order to receive the caloric as well as the immunoglobulins that they need intrinsically that they need. They know these things themselves. Latch and position techniques are considerably more flexible after the first few months. Note in the picture here that the baby is further away from the breast than when a newborn. Unless the parent is uncomfortable, there's no reason to suggest changing the position or the latch. Breast and nipple pain are a topic that many lactation consultants encounter. There are two challenges that some parents also face while they're nursing. This is one portion of a 13-page algorithm, which was developed by UNC, the University of North Carolina in the United States, for breast and nipple pain. It's a very valuable resource, and it's a good review prior to the exam for how to identify many of the causes of breast and nipple pain. And that is also included in your handout. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin, and heat, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be somewhere between 3 and 20%, depending upon the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and to abscess if treatment is not introduced promptly. Symptoms can include a fever of 38.5 degrees centigrade, which is 101 Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen, and the breast area is red, hot, and tender to the touch. Now, you may notice red blotches or streaks or bruising of the breast tissue, depending upon the skin tone of the parent. So you want to be mindful that redness isn't necessarily something which you can see, depending upon the melanin in the parent's skin. So treatment, breast is number one. Continue to feed and or pump on the affected side. Cold compresses can be helpful in order to reduce edema. Creative nursing positions. And one thing that we know which to be helpful, and this is a bit more anecdotal, I haven't seen any evidence on it, but if you, when I mention creative nursing positions, if you can point the baby's nose or chin towards the area where you notice the discoloration, then that can definitely help to release any sort of like clog or any sort of like plug that, and I describe it as a plug because people have palpated it and you can sort of feel that there's this like hard area. And so if you can point the baby's nose or chin towards that spot, the baby can take care of it. That's where their most vigorous sucking is done, at those 2 points where their nose and or their chin are pointing. Breast movement or gymnastics. Maya Bowman is an amazing lactation consultant who has a really good video on her website, which shows different breast movements and or gymnastics, which can help. It's important to support compliance if antibiotics are prescribed. Use analgesic or anti-inflammatories for discomfort, fever, and swelling. So now I intentionally chose this picture to help you try to see the mastitis. It can be challenging to note this overt inflammation or swelling or redness with someone, as I mentioned, with darker skin tones. Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding, A Guide to the Medical Profession, as a common cause of infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic women. In the case of recurrent mastitis, the diagnosis can be made with a culture of milk and infant naropharynx or oropharynx culture. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol on the mastitis spectrum. Now, a small percentage of breast infections may develop into an abscess. Kinley et al. Reported the incidence to be about 5 to 10%, whereas Amir reported about 3% of women with mastitis in her sample developed an abscess. Now, one theory is that healthcare providers are more educated on the prevention of abscesses. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. Now, LER describes an abscess as a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. So treatment options, Kataria reviewed different treatment options in their study. For small abscesses, which are less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotics, which are effective against the penicillin-resistant staphylococci for 10 days. For larger abscesses, the health provider will incise and drain the area. The drain is placed to promote drainage. The incision heals from the inside out, usually within a week or 2. A parent may continue to nurse on one or both breasts, depending on the location, associated pain, and medication. Although a very small percentage of women resume menstruation, and yes, I'm switching topics quickly, so here we go. A small percentage of women resume menstruation as early as 6 to 12 weeks. Others may not menstruate until breastfeeding has ceased completely. It's usually dependent on overall breastfeeding patterns, but not always. Now, there is no significant change in the composition of the milk. Hormonal changes may alter the taste of milk, which can prompt the baby to be fussy or refuse to nurse. Some parents feel that it temporarily lowers their milk production. It also may impact a family's child spacing plans, especially if they were relying on the lactation amenorrhea method. So nursing through pregnancy. Pregnancy can occur while breastfeeding. It's really helpful if you can explore the parent's feelings about continuing breastfeeding or chest feeding. Some people will note nipple and/or breast discomfort. Some people report that discomfort alerted them to the new pregnancy. Depending on the age and nursing relationship, some nurslings may be reluctant to wean. We know that mature milk will change back to colostrum at around 4 to 5 months into the pregnancy, which may change the taste and quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There's no need to wean a nursing baby or child unless there is a true risk of preterm labor. There's limited data which shows an impact to the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it's important the mother is mindful of her diet. Some older babies and toddlers may stop during the pregnancy and then resume after birth. So tandem nursing is the term to describe breastfeeding 2 or more children who were not born at the same time or are different ages. It occurs when a parent nurses through a pregnancy, or if previous child weaned during that pregnancy, they may be interested in resuming. Again, it's important to explore the mother's feelings about tandem nursing. As one of the pioneers in the lactation field, Shelley Marmette once said, "It takes the patience of Job to tandem nurse." If there's an issue with infant's weight in the early days, ensure that the newborn is given priority at the breast. Some parents will dedicate one breast to the newborn and the other side to the toddler, and then switch the next day. Take a look at this picture and you can see how the older sibling has her arm around her new brother. Now, granted, it may be so that everyone can fit on mom's lap, but it may also be a sign of affection. Weaning. Now, if a parent expresses a need to wean, again, explore the reasons. Some families believe that weaning may increase the child's independence or help a child sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse a child's request to nurse. Eliminating a feeding about every 2 to 4 days, and preferably not back-to-back feedings. Continue as both the parent and child accommodate to the new routine. Hand express for comfort as needed. It can be helpful to change the daily routines for the child so that alternatives to nursing are offered and explored. You could try to offer different foods or drinks just before the regular nursing sessions, and breastfeed when asked, but you may want to stop for shorter time periods. Okay, before I move on to the next section on milk supply, Sekeita, any questions we need to address?
I'm not seeing any flagged right now. Well, hold on.
There we go.
I do see one, sorry. It said, did you say abscess?
Antibiotics with abscess. Yes. Did I say abscess or antibiotics with abscess less than 3 centimeters along with fine needle aspiration? Yes, according to this article, that was what was recommended. So that is according to that research. So again, as a lactation consultant, that's not something that you would recommend to the provider, but just so that you know that yes, that is what I said. And then someone else had a question about medications, about which kind of went against what I've always learned, that it's contraindicated during breastfeeding. I'm not sure which medication you were talking about, but we can explore that further if you want. And yes, someone is commenting, don't refuse, don't offer is parent-led. It is parent-led because that's something that the parent can generate and the parent can start. So indeed, if the parent wants to be, done with the nursing and sort of like, push the nursling out of the nest, so to speak, yes, don't offer, don't refuse is one way to get started with that. Okay, now I'm going to move on to milk supply. So here is a picture of the neuroendocrine reflex arc to remind us of the physiological mechanism of lactation. Milk synthesis is an interplay, a complex interplay of hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates the prolactin secretion and the release of oxytocin. It's milk removal that enables milk secretion to continue. Now here's a slide you may have seen in the anatomy and physiology, as well as the relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures such as reduction mammoplasty or possibly insufficient mammary tissue. And postglandular would be any cause for ineffective or infrequent milk removal. Iatrogenic causes of lactation failure are those which are impacted by policies and procedures in hospitals and or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be included here. So as I mentioned, postglandular is any cause for ineffective or inefficient or infrequent milk removal. So the separation of a parent and a baby is one, pacifier use is another, and as mentioned, the perceived insufficient milk by family or staff, which can lead to supplementation. So any interventions which require supplementation, and if the milk supply is not simultaneously supported through hand expression or pumping, can also be considered a postglandular reason. So just think about what I understand is a common supplementation scenario, and it's something I ran into when I worked in the hospital. When parents are told that they have to supplement their baby, the parents may feel that breastfeeding has failed, and they're really worried about getting it started again. Now, well-meaning healthcare providers may not encourage the resumption of breastfeeding if the interventions are effective. So common scenarios include a baby who's diagnosed with hyperbilirubinemia in those early days after birth, and supplementation with breast milk substitutes is begun, or a 2-week-old baby who wasn't gaining effectively and begins to gain with supplementation. In both cases, parents may be afraid to resume exclusive breast or chest feeding or human milk feeding, And healthcare providers may not have the time to create a care plan to help the baby return to remove the supplementation. Finally, there are some cultural beliefs that create a barrier to normal breastfeeding, such as colostrum is not good enough or that it's bad for the baby. So breast or chest tissue anomalies can be included in structural issues. So as I mentioned, we've got surgical interruptions of the breast or on the chest, such as a biopsy, reduction or augmentation, a chest tube as a preterm baby, or a thoracotomy prior to mammary development. So mammary hypoplasia, which is also known as insufficient glandular tissue, mammary asymmetry, including intra-mammary distance, or the space between the breasts. So chronic illness, and I've got several slides here. So parental disease, we're talking about hypo or hyperthyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness or birth-related complications include hemorrhage after birth, especially causing large sudden drop in blood pressure and or requiring a blood transfusion. As a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues such as irregular menses, infertility, obesity-related issues, PCOS, weight loss surgery, specifically gastric bypass surgery, which can impact the amount of nutrient absorption. Other factors for delayed lactogenesis 2, which is also known as the secretory activation of milk supply, I got it, which is greater than 72 hours, include premature delivery, insulin-dependent diabetes mellitus, or gestational diabetes. Metabolic status or health refers to an interesting study from Namsen, Rivers, Donal, and Huang, which describes 3 risk factors for delayed lactogenesis, which include a higher BMI, increased maternal age, and larger infant birth weight, as known correlates with carbohydrate intolerance and systemic inflammation. Now, fat phobic bias in the staff which are unaware of their bias is another reason where families don't get the support that they need and the clinical care that they need while they're in the hospital. Other factors include hypertension, high levels of stress to the mother and fetus during birth, cesarean birth, especially when it's urgent, prolonged stage 2 of labor, which is considered to be greater than 1 hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery, the timing of the first breast or chest stimulation following delivery, significant edema of the extremities, as you can see on this photo, and endocrine disturbances. Now, as you can see, there are complex interrelationships amongst the various factors that can affect lactogenesis. Whether the delay of the secretory activation of milk production is a maternal physiologic response due to delayed or ineffective suckling, or a combination of factors, has not yet been clearly identified. Early, frequent, and effective breastfeeding appears to be the most important factor to counter the possible risk factors. For those of you who work in a hospital setting, you can understand how that could be impeded with any of the above or the previous diagnoses. Now, any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors here include gestational age, premature infants, of course. Remember that the late preterm infant may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy, and any tongue mobility restriction can impact not only the maternal nipple discomfort, but also the ability to remove milk effectively. Palatal issues, obviously, which include a partial or complete cleft of the hard or soft palate, but it also could include a high or a bubble or a channel palate. And then finally, another piece here in relation to this are airway issues, such as laryngomalacia or tracheomalacia. Long term, the issues on the previous slide can impact the initiation and calibration of the supply. The following can impact the maintenance of milk production, such as in that immediate postpartum period, infant hypotonia or hypertonia, birth trauma, pain such as shoulder dystocia, or the use of forceps or vacuum. And you could see the picture here. The parent was really happy and to have her baby skin to skin and was super excited about it. But you can sort of see, if you look carefully, this baby was born via vacuum, and you can see also the scabs on the baby's head, where the baby in order to keep an eye on the baby, and so you can sort of see the scabs from that. Now, the long-term impact include infant facial anomalies, as I mentioned, the tongue and the palate. They can also continue to be a problem on continuation and ensuring that there's an appropriate milk supply. And then finally, sensory integration issues. Now, there are a few good solutions to get off to a decent start with building a milk supply. Now, during the hospital stay, we've got, of course, frequent skin-to-skin contact. Honestly, you can't overdo that. To me, it's a solution for milk removal. Hand expression seems to work best. Now, a quick note for parents who are exclusively pumping for their premature infant, or they're having trouble extracting an appropriate amount, utilization of other senses can help with the milk ejection reflex. A study noted an improved milk output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos, as well as smelling their t-shirt or blanket from the day before. Now, it's also helpful if you can provide with anticipatory guidance about normal newborn circadian rhythms, visuals of the newborn stomach and nominal nutrition requirements in the early days, and realistic expectations are some few things that can be helpful to a parent. Realistic expectations with how the baby is doing, how the baby is going to continue to do, but also on the milk production and how much to expect. Now, you don't want to give them that sort of list and say, okay, you need to have, 250 milliliters by this day. You don't want to give them that really hard and fast number, but you do want to provide them with realistic expectations on how milk supply will increase over time. Alternative supplementation techniques, if required, can be helpful as a really good solution, and follow-up. Okay, I'm going to go into research, but I do see a note here, so pardon my fidgetiness when I notice that my sound is cutting out a little bit. So indeed, it seems to be doing it more than once, and so if there's something which I missed and or you couldn't quite hear, please do say something. Okay, I think I have just 2 more slides here. So I'm going to go ahead and get through these next couple on research. And so variables in experimental studies. So the dependent variable is what the independent variable acted upon. For example, in a study on breast pumps, the volume of milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable. The type of pumps is the independent variable. Now consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent was pumping. That could lower the amount that they're able to extract, or time of day could also be a compounding variable. Those of you who are actively working in the field will report that many parents will note that earlier in the day they get more milk out as opposed to later in the day. So I just want to quickly review some frequently used terms in research. So the standard deviation is a measure of how spread out the numbers are. So 68% will fall in the first standard deviation, which is marked by those 2 middle columns in green. 95% will fall into the first and second standard deviation, and 99.7% will fall into the first, second, and third standard deviation. So you're just going to have a few on either end in the fourth standard deviation. So statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05. This is most medical research. Now, a comment here about bias. There are different types of bias, and it can influence research. For example, there we go. For example, a piece of research which looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute. Now, let's say that you note that the university who supported the research is funded by a specific pump company. The researcher whose university receives that funding from the company could be biased in their study design and/or the interpretation of the results. Informed consent. Subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and how to withdraw from a study at any time, as well as any rewards for participation. Okay, those are my 2 slides on research. I know I've covered a lot. Julie, I see that you mentioned that there is a 2-part question here, which is good. Okay, great. So let me see where that is. Sekeita? Oh, great, Julie, you saw the comment about fat phobia. Thank you very much. So endocrine versus autocrine lactogenesis, and when this shifts around day 9, which is considered part of L2 or the secretory activation. So L2 is half endocrine, half autocrine. Then L3 is galactopoiesis, which is all autocrine. Great. Let's see.
Angela, I'm trying to find the 2-part question. I believe it was answered, but I was also deep in my book trying to look for an answer. So I don't see it.
Is pathological engorgement only referring to engorgement from breast surgery and trauma? And regular engorgement is early postpartum is different, more so from the regular expected physiologic switch in early lactation? Is pathologic engorgement only referring to engorgement from breast surgery and trauma? No, pathologic engorgement could happen because, for example, if there is a significant amount of IV fluids which are used during the labor process, that could be an issue. So hence Julie stated from poor lactation management. So that is something which could be an issue. So no, it has to do with the lymphatic fluid that can get any edema in the breast, but it also could have to do with the milk and the milk unable to flow from the breast. And so hopefully that answers your question. When do those tight junctions start to close postpartum? Was it about 12 hours? Actually, during lactogenesis 2, which doesn't seem to happen before day 2 or 3, that's true. When do you expect L3 to be fully autocrine? You know, that's really, it depends on so many factors. So that I do not know the answer to off the top of my head, but I'll look it up when we go to question time. Oh, L3 is fully autocrine. Thanks, Julie. That's why we have Julie on the call. Thank you. What would a question look like on p-value? I'm still trying to understand this. So, you mean what would a question look like on the exam? Well, it has to do with the statistical significance. And so I think, Sekeita, you came off. So it has to do with the statistical significance and whether or not they present a piece of research and they say, and they're asking a question. I assume they're not going to say yes or no, is this statistically significant? Because all you have to do is take a look at the p-value. That is, as long as it's 0.05 or less, then that's going to be the response. So do you have another idea here, Sekeita?
No, I was just going to say exactly what you were saying in a different way, is that if it's less than 0.05, you can be sure that the research results are clinically significant enough to say this is good. This is good research, right? If it's like greater than, then you're going to be questioning those results. But again, Angela brought up a good thing. There's also limitations. There's also bias, there's confounding factors. So you just can't look at that. But when you're thinking about the actual p-value of something, that's exactly what it means. If it's less than 0.05, that means it is some significant evidence to say, oh, let me take a greater look at this. And should I be teaching my clients this, or should I be incorporating this into my practice? Is this a sound is this comes from a sound, actually significant, big sample that this turned out that it was less than 0.05.
Good point. Okay, great. So now, hopefully Jill is ready. I think it's question time, is it? Let's see here. Okay, it is question time. So this is interactive, so y'all are going to have a chance to choose which answer you think is right. So remember that we're talking about overall concepts here and not what is done at your facility or in your country. For example, you may see a reference to varicella zoster in one of the subsequent questions. Hint. During the previous exam prep, we reviewed recommendations for varicella zoster, and we found 3 different answers. When that occurs, please look to the international resource. If there isn't an international resource or a clear-cut answer, understand the why. One may be able to assume that there will not be a question about it on the IBLCE exam if there is conflicting recommendations. Okay, so I'm going to put the question up, and then after you all get a chance to read it, because some of them are going to be pictures, after you get a chance to read it, then Jill is going to pop up the question so that you can respond. Unfortunately, the poll doesn't allow for the picture and the slide to show at the same time. Okay, here we go. First question. Physical presentation which may contribute to low milk supply is A, significant inframammary fold, B, a breast cup size less than B, C, significant intramammary distance, or D, hypoplasia of the superior breast tissue. So there's the question. Jill is going to pop up the question. There we go. Thanks, Jill. And when she pulls this up, so we'll give you guys about 20 seconds to respond. Also know that there is a sophisticated distractor here. And a sophisticated distractor is one which sounds like it kind of could be the right answer. And if you don't really know the definition to it, then you might pick that one. So just FYI. Okay, great. Go ahead and close it, Jill. All right, so the answer is C, the significant intramammary distance. So that distance between both of the breasts, that is the physical presentation, which may contribute to low milk supply. Okay, great. Now, we'll go on to the next question. A post-glandular reason for insufficient milk production is A, early introduction of hand expression, B, pacifier use, C, retained placenta, D, previous breast biopsy with the periareolar incision. Okay. So what is a post-glandular reason for insufficient milk production? Early introduction of hand expression, pacifier, retained placenta, or previous breast biopsy with a periareolar incision. Give you another few seconds to respond. Post-glandular. Okay, great. So yes, most of you got this correct. The answer is B, pacifier use is a post-glandular reason for insufficient milk production. Okay, great. Moving on to the next one. While reviewing your postpartum patient's chart, you see they receive Pitocin or synthetic oxytocin and Methergin, methylgrenovine maleate. I didn't practice it for the webinar. Many apologies. After a vaginal delivery. You know this patient most likely, A, experienced normal blood loss, B, experienced excessive blood loss, C, gave birth to multiples, or D, will not be able to breastfeed. So you notice in their chart, thanks Jill, they received these 2 medications after a vaginal delivery. So what is going to be your assumption here? Give you another few seconds. I'm not fooling anybody here. Okay, great. So yes, 92% of you said experienced excessive blood loss. Yay. Yep, that's correct answer. You know, the first line of medication used in the management of excessive blood loss during the 3rd and 4th stages of labor is Pitocin. If the bleeding doesn't increase, a second medication is usually indicated. Providers may choose among several medications, including Methergin. A is not correct because the management of normal blood loss does not require 2 medications. And C is not correct because the delivery of twins doesn't require 2 medications. So, and D is incorrect because excessive blood loss doesn't necessarily mean that breastfeeding will be unsuccessful. Okay, great. So here we've got a research question. LELO lactation consultant did a study in their hospital. Families were randomly placed into 2 groups. One group received an intervention and the other group received standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, thank you. So families were randomly placed into 2 groups. One group received the intervention and the other group received the standard care. What type of research is this? I think a few of you are changing your answers. That's good. Usually. Sekeita's going to review that in her next session about whether or not you should change your answer. Okay, great, Jill. So yes, the answer is quantitative because it's based on data. It's not experimental, and there's no attempt to determine causality, right? It's just the description here. Okay, good. Next question. Oh, here we go. So qualitative research, here's the explanation. Qualitative research, it's exploring real-world context based on perceptions, considers multiple perspectives, there's no attempt at causality, and use of interviews and observations. Quantitative research is experimental research to discover causal or correlational relationships between variables, and it's based on data collection and analysis. Okay. Next question. LELO lactation consultant is a busy person, and they did a study in their hospital where they surveyed patients about their satisfaction with breastfeeding and what type of problems they encountered. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, good. Again, not fooling many people here. Great. Okay, good. Yep, 80% of you got it correct, qualitative. And so if we take a look at, again, what the answer is, qualitative research is exploring real-world context based on perceptions, considers multiple perspectives, no attempt at causality, and use of interviews and observations. So that is great. Okay. Next question. Iron levels are low in breast milk. What recommendation should parents be given? A, to supplement iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet to increase the amount of iron in your human milk. Okay, so what is the response here? Okay, good, you're getting closer. 1 or 2 more people answering. Okay, thanks, Jill. All right, this one is a little trickier, and I don't mean tricky like in a tricky, like trying to fool you, but we've seen information on the internet about what answer would be correct. So additional iron intake by the parent will not increase the iron levels in the human milk, even if the parent is anemic. Iron supplements taken by the parent may produce constipation in the baby Anemia in the nursing parent has been associated with more milk supply, in poor milk supply. So the correct answer is C. Breastfeed and supplement at 6 months with iron fortified foods. Okay, great. Next question. Vitamin D levels are low in breast milk. What are the current recommendations? A, supplement baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half hour outdoors every day. Or D, baby should be supplemented with 400 IUs of vitamin D daily. Okay, great. So which one is it? What are the current recommendations for vitamin D levels in human milk? Give you another few seconds. Finish up. Okay, great. So yes, the correct response is D. Babies should be supplemented with 400 IUs of daily of vitamin D. And this is actually from the World Health Organization. There appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets. So that is a response from the World Health Organization. As far as the second response there, breastfeed and spend a half hour outdoor every day, well, we can't necessarily control like where in the world that person and or baby are. So, you know, some areas have more sun than others, and I have actually heard of babies getting sunburned when they're not properly protected. So that's why that is not one of the recommendations. Okay, great. So this is a picture, all right? So take a look at this baby. And the question is how old is this baby? Now, just to give you a couple of hints, okay, we've got here a social smile, and the baby is able to lift their head about 45 degrees, and they hold their head up for just a few seconds, and they're visually searching to locate that familiar face or sound. Okay, so is the answer 2 weeks, 4 months, 2 months, or 8 months? Okay, you see the baby. All right, Jill. Thank you. How old was that baby? So yep, we're pretty tied here. We're pretty tied amongst two of the responses. And about 80% of you voted. So let's go ahead and close it out, Jill. All right, so now note that this one is demonstrating how they can hold their head up and begin to push up when lying on their abdomen. Now at 2 months, they may not be able to sustain this pose, but the parents are at her level, right? So they're sliding down, sorry, they're coming down and they're getting a picture of the baby, old school camera here, getting a picture of the baby just to show off how strong this baby is. And so the correct answer is 2 months. And yes, half of you picked 2 months and half of you picked 4 months. I completely get it. That is something where you'd really have to know a little bit more background, which is why I gave you those hints that it's a social smile. They can lift their head 45 degrees and they can hold their head up for a few seconds. A 4-month-old is going to be able to sustain it more than a few seconds, but a 2-month-old will not. Okay. I hear you. Y'all are saying, that's not fair. Just thought I'd give you a little example of some of the photo questions. Okay. Which of the following viruses is most likely to be transmitted to the infant through human milk from an infected parent? A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, or D, cytomegalovirus? Okay, so which one is it? Hepatitis C, herpes simplex virus, varicella zoster, or cytomegalovirus? What is the one that is most likely to be transmitted to the infant through human milk from an infected parent? We could change that from an infected donor. We could change it to an infected if the person who is donating milk informally. I could keep adding, but I need to stop. Okay, so go ahead and close it, Jill. Most of you have responded. So actually, the correct answer is D, cytomegalovirus. So CMV transmission from parent to infant occurs in 60 to 70% of breastfeeding dyads where the breastfeeding parent is infected with CMV. However, healthy infants, one second, here we go. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive human milk. Herpes simplex virus, or HSV, and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with skin lesions. And yes, I know that this recommendation is something which is slightly different. If the parent is infected with the varicella zoster virus in those last day or in the last few days prior to giving birth and the first few days after giving birth. So I know that there's a caveat there, but notice, take a look at the stem of the question and see specifically what it suggests. Okay. Next question. Tyler's diet is vegan. What would you suggest to ensure adequate nutrition for Tyler and baby? A, proteins from beans and rice. B, minerals such as magnesium and selenium from grains. C, folate from dark green leafy vegetables. Or D, B12 from fortified foods or supplements. Okay, so Tyler is a vegan, prefers a vegan diet, or is required to have a vegan diet. Let's not make assumptions here. So what is the correct answer? What does Tyler need in order to ensure adequate nutrition? Okay, that's great. We've got about 80% of you who responded, and yes, the correct answer is D, B12 from fortified foods and supplements. So a vegan is someone who includes no animal products, and that is the only dietary source of B12. To avoid that B12 deficiency, vegan nursing parents and those who consume very little animal protein need to take steps to ensure they receive vitamin B12 either from their foods enriched with B12 or by taking a regular supplement. Okay, next question. The primary reason for providing human milk to premature infants is to, primary reason, improve bonding between the breastfeeding, chest-feeding parent and baby, assured continued breastfeeding or chest feeding after discharge, significantly decrease the risk of necrotizing enterocolitis, or D, improve neurological outcomes. Okay, what's the correct answer to this one? Primary reason. You know, Sekeita, I have to say, I'm impressed with the folks who are going to take this exam. Y'all are gonna do very well on this exam. So, not that I have any data to support this, it's just a feeling I have. Okay, thanks, Jill. So yes, the majority of you did get this one correct, which is preventing necrotizing enterocolitis. And while all of them are important, it's the primary reason for providing human milk. Okay, next question. The potential risk of skin-to-skin care in newborn infants includes A, respiratory instability, B, sudden unexpected postnatal collapse, SUPC, C, hypothermia, or D, sudden unexpected infant death, SUID. So what is the potential risk for skin-to-skin care in newborn infants? Respiratory instability, SUPC, hypothermia, or SUID. And this is something which was published, I want to say about 15, maybe 20 years ago, actually. This phenomenon, or what is occurring here when it has to do with newborn care, skin-to-skin care in the newborn. Okay, great. So thanks, Jill. So you'll notice here that yes, the correct answer is B, sudden unexpected postnatal collapse. And so do take a look at the research on this one. Susan Ludington-Ho was one of the first to describe this phenomenon, and there are checklists that can be employed to ensure that SUPC is not an outcome which occurs during skin-to-skin care in that early newborn phase. Okay, last picture. I got 2 questions left, so here we go. This hand technique is useful for all infants except A, premature infants, B, Down syndrome infants, C, neurologic impairment, D, infants with type 3 ankylosing. Okay, so what is this hand technique is useful for all infants except, and since you can't see the picture, I'll demonstrate here. So this is what the picture is. Kind of giving you a hint here a little bit by showing you what you can't see on the other side of the picture. Okay, great. I didn't fool you. But yes, the correct answer is infants with type 3 ankylosing. So that is one which this technique may not be as helpful for. So remember, there's not going to be many. This is known as a negative STEM question. There's not too many of these on the exam, but they may happen. So do be mindful of those keywords like except and primary and things like this. And if you want more information about that, we have a webinar that we did 2 months ago on 90 days and counting. So we've got a few helpful things in that and a blog post as well. And by the way, this is known as the dancer hand position. It's a straddle hold of the baby with the dancer hand position. Okay, the World Health Organization guidelines for preparing powdered infant formula recommend A, boil the bottles and teats for 20 minutes or a rolling boil. B, boil the water used for mixing for 20 minutes, a rolling boil. C, mix the measured amount of powdered formula in hot water, 70 degrees centigrade and 158 degrees Fahrenheit. And D, store prepared bottles in refrigeration for up to 72 hours. So yes, here we go. So what are the WHO guidelines for the preparation of powdered infant formula? Which one of these is recommended? It seems like people may be changing their answer here, which is fine. This one, you really do need to read all the words in the selections in order to know. And yes, I'm giving you an extra second or two. Okay, a majority of you have answered the question. All right, so this one is the correct answer, C. So mix the measured amount of powdered infant formula in hot water at 70 degrees centigrade and 158 degrees Fahrenheit. So do you need to boil the bottles and teats as well as the water for mixing? Yes, you do, but it's not 20 minutes. And the preparation of the bottle, the commercial milk formula bottles, can only be stored in refrigeration for 24 hours, not 72 hours. So I think several of you may want to go back and take a look at the WHO guidelines on this in order to make sure that you've got this one straight. Okay, great. Now we're going to take a moment and see if there are any questions that I missed as I was going through the questions. Okay, Sekeita, let's see here. Isn't it using boiled water and letting it sit for 5 minutes in powder? No, so, go ahead.
I do want to say, like, this is one of the things in practice that as a lactation consultant is like, when I think about the amount of times that I'm going into homes and I'm doing lactation consults, but then there may be mixed feeding where they're preparing formula and I'm like watching the formula being prepared and I'm like, oh, whoa, now we have to stop talking about this lactation issue and we have to deal with teaching. And it's just amazing to me that this is just not common knowledge, particularly in light of the shortage that happened and multiple times, not just recent shortages, that infants the formula has been contaminated with Chronobacter and Salmonella, that it's not more common knowledge. And so that is one of the things I wanted to say. The other thing I wanted to say is I was noticing in the questions, there was a clarification about Methergin and Hemabate. And I want to say that for us that work in healthcare, one of the things that's going to be very crucial to remember is the question is asking you for one thing. So we might have all these other extenuating knowledge about these medications, but if they're only asking you a certain question, please don't like in your head be like, well, I can't give it if this person, because it didn't say that this person had asthma and it didn't say that this person had hypertension. So I'm going to just really just preface that, which, you know, I'll get into some exam strategies, but really wanted to say that that was a great point and a great reminder for me to say exactly that, is that only look at the question at face value for what it's asking you. But yeah, I think like you, Angela, I think this group is prepared. I think, you know, they'll be successful. So I'm excited about the way the questions were answered.
Me too. There are a couple of questions here about powdered formula. So the key about powdered formula is, although the CDC has said to use water, you know, to use that, powdered formula is not sterile, right? That's the bottom line. Powdered formula isn't sterile. And the CDC says that you need to boil the water until the baby is not immunocompromised, or is it 2 months old or 4 months? I think it's 2 months old, right?
It's 2 months.
But we're talking,
formula is not even recommended for infants less than 2 months of age.
But you see, that's a CDC suggestion. That's not World Health Organization.
Correct.
So
World Health Organization is the boiling of the water, though, which
is the boiling of the water, yes, and and you have to add it hot to the powder within, you know, before it cools down to that 70 degrees centigrade, right? So that's the important piece of it there. And someone is commenting how, you know, that this method is not even taught in the Women, Infants, and Children program, which is the nutrition program for some parents in the United States. And you're right, it's not. And I could go on, but I won't, as far as the why, right? We're not going to.
Yeah, I think we both could go on about our passion, and I'm so glad this seems like a passionate group. First of all, based on the feedback and the questions, so I'm loving this because it sounds like you're just as passionate as we are about this. So
I know, I love that. Yeah. Okay. So, and what about using powdered formula? Yeah. So, as far as how long to boil the bottles and teats, I know it's not 20 minutes. I want to say like maybe it's like 5, but don't quote me on that. Right? Go take a look at the guidance from WHO. So hopefully you should be able to find it easily. Okay, Sekeita, exam day survival guide, best part of this.
Yes.
Go ahead.
Well, thank you. I think they're surviving just well, though, based on how you all answered the question. But let's talk about this. I want you to just really take a moment, though, right now, and just kind of stop and soak in all the things that we just talked about. And I want you to give yourselves a hand for real. Like, getting to this day is not by any means something that we should not be celebrating. The fact that you have an actual date to sit the exam, because just as I said, it takes passion, dedication, and endurance. And this group is passionate based on my comment that I just made. But arriving at this day, or arriving at the point where you can take the exam, is truly a reflection of that passion, dedication, and endurance. So if you have not given yourselves a hand yet, please do, because this is not just something that's very light. All the like I hear people say, blood, sweat, and tears. I know for me it was the same, having to do clinical hours and then having to study and having to make time to study with families, with other obligations. So yes, please delight in the fact that you're here today and that you're still continuing to make this thing a reality for you. So there's that. So we're going to jump into the last few days of basically how to stay connected to this passion, because your days are winding down. A lot of people are on a countdown, but you still want to stay. But how to celebrate and just trust that by the time you get to that day, the date of test day, that you have full trust in your preparation. So even if it looks like or seems like that you haven't been able to prepare up until now, just know you have about 30 days left. and just make the best of it so that you can really trust that you put in enough time to make sure that you're successful. And then breathing deeply, I cannot stress this enough for me. And I think for everyone, just remembering when we say breathe deeply, it's not just like these shallow breaths that we take throughout the day. It's really taking a moment to be intentional and doing a and letting it out through your mouth. For those of us who may have worked in labor or work around laboring people, that is something that works during the labor process, but it also works to help calm nerves. And so throughout this time, when you're taking a moment to study and when it seems overwhelming, don't forget to take that breath, because it also increases oxygen to your brain. So not only does it calm us, but it does give us that extra boost of oxygen that's sometimes required when we need to keep going. So we're going to start to talk about before the exam. Basically, have your information, your confirmation information. Know that there are computer system requirements for those of you who are maybe taking the exam through live proctoring. Be familiar with what is expected of you. There is an actual website that you can go to so that you can find out all of this information. If you do nothing else, please do that. For example, if you're taking the test at home, know that there are certain computer requirements that must be in place before the date of testing. You cannot test on a tablet at all, and you will need a stable internet connection. And for the live proctoring, which means that you're taking it at home, there are 3 security checks. There's your photo ID, and then they actually do an environmental check of your workspace. So that includes your camera being able to scan the entire workspace, the entire room. And then the third check is a personal check of you. And this includes you showing your ankles, turning your pockets inside out, raising your shirt sleeves up above your wrist. And if you wear glasses, you have to remove them for inspection. You have to remove your jewelry. You have to have your hair pulled back. Whew. And then once that's done, you can begin taking your exam. So you really want to really know, especially those that are live proctoring at home, what to expect. And you also want to have enough time allotted so that you can get those checks, those security checks done. The other thing I want to ask of you is, if you do not know the terms of automatic exam termination, you also need to read and review those terms before you sit the exam. So when we're talking about the specifications for your computer, again, I already mentioned that it can't be a laptop. It can't be a tablet. You may use a laptop or desktop computer. However, you can't have dual monitors. You can't have 2 monitors. That is not acceptable. Chromebooks are not acceptable. A Microsoft Surface Pro is considered a tablet for the sake of the live proctoring, and that may not be used. And so you really want to understand the specifics of it. You need a movable webcam for that security check process that I just talked about. And know that a webcam that's on your laptop is acceptable as long as you're able to move your laptop and scan the entire room. And you may not have more than 1 web camera, all right? A power source, you need to plug directly into the wall and not a docking station. That is the recommendation. And again, you have to have working speakers, and a microphone is required. You are able to use wired headphones and wired microphones. Again, if you don't know what to do regarding technical difficulties, please prepare yourself by visiting the Live Remote Proctoring website. If you're sitting the exam in person, make sure that you try to arrive at least 30 minutes ahead of time. An early arrival with your 2 IDs that match your name on file with IBLCE, okay? And be sure to make sure that you've checked your local testing area to see what safety precautions they are abiding by. If you maybe possibly still need masks, you do want to just check in and make sure that you're following their safety recommendations. All right, so taking your exam temperature. Some of you may have already taken your temperature just by how you answered those questions that Angela just went over. But I really want you to think about other exams that you've taken in the past and what worked for you. So, you know, if you are trying to do a new study process and you're trying to do something different, see if that's working for you by how you've tested, how you answer questions. But basically think about what's worked for you and continue to do that. You know, if you feel good and you have a good handle on your nerves and you feel like you're almost at that point where you're like, I'm almost ready, stick with it. But if you're nervous, you might need to take some steps and take some different steps to kind of figure out what your areas for growth is and really focus on those areas. And so really take some time to be intentional about, you know, what's worked for you and where you are as far as your preparation. And when I talk about preparation, I cannot resist but to say this quote that I love. And it says, many students cannot pass their exam because they failed to sacrifice the minimum capital of time and money. And when I think about the capital of time, you know, time is really, really, really important as the days go by so much faster and you feel like you don't have enough of it. But now is the time to buckle up and kind of make time. So capital of time is also a thing. And also sometimes you have to invest monetarily in other testing websites to make sure, or books, or whatever that thing may be to help you pass the test. All right, so before exam day, you want to make sure that you are alone. So if you have a pet or if you have a cat, you want to make sure that they are somewhere, or any type of animal, so they're somewhere that they will not enter the space. All right, you want to make sure that the area where you're testing at has a strong light and the internet is good. Everyone in the house should stay off the internet. No streaming, no social media, especially streaming movies, none of that. Everyone should stay out. And you might want to consider hardwiring into your computer, to your internet system, okay? And just make sure that you have quiet time, because there should be no noise, no person, no one should interrupt you. That could be automatic grounds for termination of your exam. Even a cat coming up and behind you can be automatic termination. And so you want to be sure that you have made provisions for all of those things. All right, before the exam, like the night before, or as you're leading up to it, an exam playlist or a podcast, or just affirmations to yourself, or setting small goals to yourself. Remember, I talked about opportunities for growth. If you notice that you're struggling in an area, for example, when I talked about the lactation pharmacology, and then you all of a sudden read that chapter and you have such a greater understanding and you're like, whoa, I really understand this now. Write affirmations to yourself about how far you've come along this path before the exam. For me, for example, I do have a playlist, like when I get ready to present, and I'm a nervous presenter. So when I get ready to present, the song that I listen to on my playlist, the first song is by Diana Ross, I'm Coming Out. Because it means I have to get myself hyped. I have to get ready to be live for you all. I gotta, so I hope you feel that, like I get hyped. And so same thing for exam, just get something that's gonna ground you into like hyping yourself up that you can do this, like you got this. All right, so finding your inner calm. A lot of that is based on just the night before the exam, trying to cram, like sometimes that can be our worst strategy, because now we have all things mixed up in our head. Before, just find your inner calm, whatever that is. Sometimes that's meditating, sometimes that is just reflecting on some of the, again, opportunities for growth. Don't study anything that you already know. Don't go over the things that you already know. Just try to be at peace with the fact that you've prepared and you're ready. The day of the exam, don't eat anything exotic. I know some people will be like, oh, I'm going to treat myself. I'm going to have this nice big breakfast. Eat something your body is used to. wear comfortable clothing. Even if you're testing at home, wear comfortable clothing. There's no need to and even if you're going to a testing center, there's no need to dress to impress. Just do your best because you're ready. The testing format is 175 questions. There's going to be 2 parts to this test. They're multiple choice. And then the other part to the test is images, okay? Usually you have 4 hours to take the test. If English 30 minutes if the exam is not in your primary language. Each question has only 1 correct answer, and there is no penalty for the wrong answer. So please make sure you answer every single question. It's to your advantage. All right, exam strategies. I alluded to this when I first came on screen after the testing questions. Make sure that you read the question slowly. Don't try to read into anything that isn't there. Think about what you would do first. Obviously, you want to eliminate the wrong answers first. So say, for example, you have 2 answers there that you know absolutely are wrong. If you can eliminate those and you just really are sitting on 2, then you really increase your chances of getting the correct answer. And Angela already alluded to this about watching out for negative STEM questions, those questions that are like what is not, or what is least likely, or everything except, right? You really want to pay attention to that. The other thing is to remember this is an international exam. For those of us in the US, it is not a US specific exam. So for example, hand expression is one of the things that is always going to probably be preferred over pumping, because not every geographical area has electricity or has pumps or anything like that. So review HIV protocols that are global protocols and global recommendations. Those are the recommendations that you really want to focus on, because this is an international exam. Exam strategies: work at a comfortable but thoughtful place and a thoughtful pace, I should say. And I'm trying to speed up for the sake of not holding you guys longer. But I said that to say this is a 4-hour exam, so you do have to keep it moving, but you want to recognize and be cognizant of the time. If you have any questions that you're like, I don't know, I want to come back to this, answer it. You will be able to flag it if you have time, but answer it to the best of your abilities. You just move forward. And then if you have time after you've completed it, then go back and answer those questions that you flagged. As Angela said, first impressions is usually your correct answer. You want to resist the urge to go back to your second answer. The one thing I will say about that is sometimes, very rarely though, is that you're like, how did I get that wrong? I had a brain fart. Like, I know that answer. In those instances, yes, change it. But if you're just not sure, don't sit and second guess. The first question or the first thought, the first answer that comes into your head is usually the answer. And again, don't read into the situation. Answer the question based on the information given. I've already said that. Go ahead. This is the space where a lot of times people have been disappointed in being immediately terminated or dismissed. So you cannot leave the examination workplace at all. The only time you have a break is permitted between parts 1 and 2. And you have to alert the proctor before moving away from your web camera, even during the break and even after you finalize the exam. Leaving the web camera without acknowledgement from the proctor, including during your scheduled break, will result in an immediate dismissal from your exam. And there's no third party or person that may enter the room. I already talked about that. Also, turning off your light or computer audio, or moving from your original testing location, or speaking to or receiving aid from any other person is strictly prohibited. All right, when you're done, you're done. When you are completely done with the test, there are some people who are just like, I'm done. Okay, I'm glad that's over with. There's other people that's ready to really just paint the town or light something on fire because they're so excited about the fact that they have, done this. I'm not saying light something on fire, like literally, but you know what I'm saying. And some people are so confident, like they're like, I'm done. Whatever the case may be, try not to think about the results, but click submit and be ready. No, I just said waiting on the results is so easy to think about, but you will think about it and it will eventually fade. But try not to obsessively check it. Don't try to check social media. Remind yourself you did the best. Just this is the time to cultivate relationship with your new professional community. It's the time to keep learning, keep growing, keep networking, keep trying to figure out what either your business plan is or where you're applying for your next job at. And lastly, remember your why. Whatever that why is, it looks different for all of us. And I just want to wish you good luck and best wishes.
Yay, Sekeita, wonderful.
So,
Okay.
were there any questions while I was talking? I was trying to get through that really fast because
There were a couple. Someone says, how do you wait for the 3 months for the exams? And I could explain exactly what happens. And I made a comment. I'm like, yeah, the struggle's real. It is. I understand. And there is a reason why. I actually have a blog post about the why. It takes so long to get those exam results, but there is a decent reason why, and not the least of which is they actually track the statistical performance of each one of the exam questions to see how it performed. And so that rigor and that additional statistic review is something which is necessary and beneficial to ensure that it is an appropriate exam. And then somebody asked if there are any tricks. There are no inner ways of getting the results or anything like that. I mean, I've known people who tried and it's like, yeah, that's not happening. The exam, as Sekeita was talking about, the exam rules for taking the exam are no joke. And the same is true with getting those results. It is locked down. And so trying to find a way, a back door in, it's not going to happen. So
there is a question about whether you need a computer when you're going to a testing site. No, you do not. The computers are there for you. But again, this is an international test. So what I'm going to say is check your local testing site regarding their recommendations and requirements. I wish, and you can even go to the live proctoring. You can go to the website and it'll, not live proctoring, I'm sorry, the IBLCE website where it talks about in-person exams. They do have some information and guidance for you as well. Yeah.
Yes. And someone asked about, can they request to express milk during the break or at some point? So definitely you want to check with IBLCE about that. I know that they do have a policy about nursing the baby and or milk expression. And so please do check on the IBLCE website. And always, someone's asking about ID, you want to check with the testing center in order to find out which ID it is, what you actually need in order to take the exam. So.
There's a question about, is there an essay or written questions or is it multiple choice? At this point, it's a multiple choice test.
It's all multiple choice. Do you want to answer the question about how does the exam compare to the questions in the LER test bank? I've heard the exam is harder than the NCLEX and pediatric NP exam, but don't find, so yeah, would you care to comment on that one?
I've taken the exam, I've taken the NCLEX. I wouldn't say that it's harder. What I would say is it's comparable. And so I will also say that the thing about this test, though, is that there is not trickery. There is nothing trying to trick you. There's straightforward questions. But if you are not, for example, grounded in the work or not practicing in the work or had your clinical hours, sometimes, because this is just foundational knowledge here, this is a novice, this is an entry to practice test. So it's not like on a level where you're going to get a client who is intubated on life support or respiratory support. No, it's not that. This is an entry-level test, so you have to keep that in mind. But I do feel like the level of attention and the level of knowledge that you have to have it. It's foundational.
That's true. People are asking, what's the passing score? So they do change it each cycle. And so, Julie has mentioned here that the last report, and they actually have a test analysis. IBLCE publishes their test analysis report, TAR, and so they do publish their test analysis report, and it's anywhere from, I've seen it anywhere from about 75% to around, the last time it was about 78% about a year ago. And so indeed, then these are the initial candidates, right? These are people taking it for the first time. These are not people recertifying by exam or those people who didn't pass the first time. So there's that. Julie also further, and what percentage is a passing score? The lowest passing score of 124, where they got 51 wrong, and the highest had 135 or 40 wrong. The latest cycle had a cut score of about 132. So know that IBLCE publishes sort of like aggregate data, but they don't provide specific data. And so no one has the information necessarily. There have been some students who've shared some of this information with us, but essentially, we don't, it's not something that is public, that's public knowledge. To the question about whether or not it's ever, if it's all computer-based, yes, it usually is computer-based. As Sekeita said, they will provide you with a computer. In very rare instances around the world, there could be an option for paper and pencil, but that is exceedingly rare these days. I think the last exam administration was all computer-based, but there have been in the past, there is a history of it being paper and pencil, and I took it paper and pencil. That was fun. Okay, great. I think that's it.
Wow. Well, this has been a very engaging group. I am so thankful for your questions and your challenges. Like, I have on my textbook some of the questions I was like looking up myself. So thank you for that, for your questions and for your engagement. Yes.
We have our books right here, just ready to go. So good luck to all of you. Do continue to study. Don't wait till the last minute. Do continue your studies. Find those things that you know that you really need a little bit of support with, and you've got this.
You've got this. Have a great day. Bye.
Bye, everybody.